This is Dr. Jeremy Leonard with Dr. Mario Gaudino from Weill Cornell Medicine in New York. On behalf of the Radial investigators, we are going to be discussing the Radial Artery Database International Alliance, or the Radial project, and the lessons we have learned thus far. Before we can discuss our exciting investigation, we must examine the history of CABG and arterial revascularization. We know that the first coronary artery bypass graft surgery was successfully performed in humans more than 50 years ago. David Sabiston initially used autologous vein grafts in 1962, and Vasily Kolosov reported the first use of an internal mammary graft just 2 years later. 2 decades later, Floyd Loop and his colleagues were able to demonstrate a long-term benefit in survival when an internal mammary, as compared with a saphenous vein graft, was used to graft the left anterior descending artery. In 1973, Carpentier advocated for the abandonment of using the radial artery as a conduit in CABG due to a 35% incidence of occlusion or narrowing. However, in 1993, Dr. Akar, who worked with Dr. Carpentier, advocated for its revival and reintroduction in use in CABG. The grafts which Carpentier thought were occluded were thought actually by Akar to have been in spasm and not permanently occluded. We know that isolated CABG surgery remains the most frequent cardiac surgery procedure worldwide, with the Society of Thoracic Surgeons reporting that these cases made up 69% of cases in the United States in 2017. While the mainstay of CABG has been utilization of the left internal mammary artery to the left anterior descending, with other sites receiving vein grafts, there is a growing field of literature to support the use of multiple arterial grafts in CABG. There have been several randomized controlled trials which have compared the outcomes of the radial artery and the saphenous vein in CABG surgery. Most of these trials have, in fact, shown that the radial artery grafts have better patency than the vein grafts. However, no trial has been able to demonstrate a clinical benefit of using the radial artery as opposed to a vein graft. None of the trials were appropriately powered to detect a difference in clinical outcome. Thus, because most surgeons are more comfortable with vein grafts, fewer than 10% of patients receive multiple arterial grafts in the United States today. Thus, we had a problem which required investigation. Either we need a new randomized controlled trial which compares the radial artery to the saphenous vein in CABG and which is sufficiently powered to detect a difference in clinical outcome, meaning either a major cardiac event and possibly mortality, or we need a different way to gain statistical power that's sufficient to assess the data which already exists on this topic. Before we can discuss the Radial project, it is important to take a closer look at the studies which have already been completed comparing the radial artery to the saphenous vein in bypass surgery. The first study to look at is the radial artery versus saphenous vein patency trial, also known as the RSVP trial. In 2008, the investigators published the 5-year angiographic follow-up data. At the Royal Brompton Hospital, 142 patients were enrolled in the study. These patients were randomized to receive either the radial artery or a saphenous vein graft as the conduit to bypass the left circumflex artery. 94.4% of patients were eligible for repeat angiography at 5 years. However, only 76.9% of these patients were actually submitted to the imaging. The investigators found that the radial artery grafts had a patency rate of 98.3%, while the vein grafts had a patency of only 86.4%, a difference which was statistically significant. In the published manuscript, the authors acknowledged that the study was not designed to assess clinical outcomes, and thus, nothing definitive about these outcomes can be said from this trial. Only 1 patient total died within 30 days of surgery during the trial. The only statistically significant postoperative outcome was a higher incidence of delayed wound healing in the group of patients who received saphenous vein grafts. Furthermore, at this 5-year follow-up time point, there was no statistically significant difference in survival between the two groups. The major points from the RSVP trial are as follows. The study was not powered to detect significant differences in clinical endpoints, and the only significant outcome was delayed wound healing in the saphenous vein group. We now turn to the stand-and-Y mammary study conducted by Giuseppe Nasso and colleagues out of Italy, with results published in 2009. The objectives of the stand-and-Y mammary study were twofold. First, the researchers sought to determine if 2 arterial grafts, rather than 1, improved results despite the use of concomitant vein graft. And second, if a specific configuration of composite grafts offered any advantage over other configurations. Of the total 803 patients enrolled in the trial, 409 patients made up the subset which permitted comparison of the radial artery to the saphenous vein conduits. In this study, all radial artery conduits had to be harvested from the patient's non-dominant arm, and a radial conduit could only be anastomosed to a target vessel with greater than 70% stenosis. At 2-year follow-up, there was no statistically significant difference in all-cause mortality. The group which received multiple arterial grafts had a mortality rate of 3.2% as compared with a rate of 4.9% in the vein group. We did see that patients who underwent arterial revascularization had a significantly higher rate of freedom from adverse cardiac events, and that the need for further percutaneous intervention subsequent to that graft occlusion was higher in the saphenous vein group. Recurrent symptoms of angina were also higher in patients who received saphenous vein bypasses and only 1 arterial graft. However, on Kaplan-Meier analysis, there was no statistically significant overall survival advantage in any of the study groups or arterial configurations. A few major points from this study. There was a limited sample size of 409 patients which did not provide sufficient power to detect differences in clinical outcomes such as mortality. The study specified that the radial artery had to be harvested from the non-dominant arm, which likely rendered fewer patients eligible for this study. Finally, at a follow-up of only 2 years, we are unable to draw any long-term conclusions about a possible survival advantage. The next randomized controlled trial we examined was the radial artery patency and clinical outcomes trial, also known as the RAPCO trial. From Brian Buxton's group in Australia, this study randomized a total of 619 patients. However, the relevant group for our purposes were the 225 patients over the age of 70 who were randomized to receive either a radial artery or saphenous vein graft as the second bypass conduit in CABG. The other 394 patients were randomized to receive either a radial artery graft or a right internal thoracic artery and had to be younger than 70. This study was specifically designed to assess long-term patency and clinical outcomes of the radial artery, the right internal thoracic artery, and saphenous vein grafts. The midterm results, published with a mean follow-up of 6 years, showed similar patency rates between the radial artery and saphenous vein conduits, with a p-value of 0.54. Furthermore, there was no difference in actuarial survival between the two groups and no difference in event-free survival. The patients who received vein grafts did have higher rates of target vessel revascularization, 3.6% versus 0.9%, but this did not reach statistical significance, likely due to the small sample size. The 10-year results of the RAPCO trial were actually presented at the 2016 annual meeting of the American Association of Thoracic Surgeons. These results, though as of today unpublished, did show better patency of the radial artery as compared to the saphenous vein. Some major points from this trial. The primary endpoint was, once again, an angiographic measure. Therefore, even when the 10-year analysis is published, it is unlikely that the investigators will be able to comment on a survival benefit, as the study was not powered to detect differences in clinical outcomes. We next turn to a study with a unique patient population. The Veteran Affairs Hospitals published a study in 2011, which was led by Stephen Golden. Their trial was conducted at 11 different VA medical centers. They compared the 1-year angiographic patency of the radial artery and saphenous vein grafts in patients undergoing elective CABG. This study, to date, is the largest to directly compare the radial artery and the saphenous vein. 757 patients were randomized over a 6-year study period. All patients received the standard left internal mammary artery to left anterior descending artery bypass, followed by the randomized study conduit, either the radial artery or saphenous vein. The study was, once again, designed with angiographic patency in mind. It was powered at 90% to detect a difference at 1 year. Almost 3/4 of the patients completed the required 1-year angiographic study. 88% of all operations utilized cardiopulmonary bypass, with no difference seen between on or off pump cases. At 1 year, there was no statistically significant difference in operative mortality between the groups. Similarly, graft patency was 89% in both study groups, and there was no difference in overall complications at 1 year. The group of patients who received vein bypasses did have a slightly increased risk of bleeding at 3.3% as compared with 0.8% in the arterial group, which was a finding that did reach statistical significance. While this study does have the largest sample size of any randomized trial comparing the radial artery and the saphenous vein, a follow-up period of only 1 year does not permit commenting on long-term outcomes. Furthermore, previous studies have demonstrated that clinical outcomes of patients receiving arterial and venous conduits diverge beginning in the 4th postoperative year. Thus, we would need a longer follow-up to determine if there is any difference in clinical outcomes. The radial artery and saphenous vein patency, or the RAPS study, was published in 2012. This Canadian study encompassed over 500 patients from 9 centers across the country. At a lengthy follow-up mean of more than 7.5 years, the investigators found a statistically significant difference in patency between the radial artery and saphenous vein at 88% and 80% respectively. Interestingly, this study utilized within-patient randomization. This means that all patients had grafts which used the radial artery and the saphenous vein. However, depending on the randomization, the radial was used to bypass the right coronary system and the vein to the left circumflex distribution, or vice versa. Overall mortality of this study was 11.5% at long-term follow-up. While the RAPS trial did indeed demonstrate superior patency of the radial artery over the saphenous vein, the results do not help us to draw a conclusion about the clinical outcomes. In their publication, the authors do acknowledge that, quote, because all patients receive both study grafts, the study is weak for the evaluation of clinical outcomes, end quote. The study does conclude to say that the investigators believe the benefit of the radial artery compared with the vein graft persists over 7.5 years. We next turn to a study from the Korean Peninsula, which was completed in 2012. This relatively small trial enrolled 60 patients. They were randomized to evaluate the radial artery and vein conduit use in specifically off-pump coronary artery bypass surgery. Further, all patients had to be over the age of 70 and undergo only isolated off-pump CABG. This study is yet another with a primary angiographic endpoint, in this case at just 1 year. The patency of the bypass grafts in the radial artery group was 97.4% compared with 94.7% in the vein bypass group, a small difference that was not statistically significant. At 1 year postoperatively, there was no difference in survival. The main takeaway points from this study are as follows. The rather small sample size of 60 patients renders this trial underpowered to detect any difference in outcomes, especially at just a short 1 year follow-up. This study is not generally applicable to all CABG patients, considering the age restriction and the requirement that cardiopulmonary bypass not be used. Interestingly, all study bypass conduits were composite grafts off the in situ left internal mammary artery rather than off the aorta. The final study we will inspect is the most recent of the randomized controlled trials completed in Serbia in 2015. In addition to being the most recently published, this trial also reports the longest published follow-up to date of a randomized trial comparing the radial artery and saphenous vein. 200 patients in Belgrade were randomized to receive either a radial artery graft or saphenous vein graft as the secondary bypass conduit. At a follow-up of 8 years, there was no significant difference in absolute survival. Not only was there not a survival difference, but there was no statistically significant difference in patency or clinical outcomes between the two groups. Radial artery grafts were only used to the right coronary system 17% of the time, with the majority of radial bypasses being to the left circumflex territory. Also, the study restricted that a radial graft could not be placed to the right coronary artery or a diagonal branch that had previously been included. Based on these restrictions and the relatively small sample size, the apparent equivalence in the grafts is not surprising. The authors conclude that the radial artery, rather than a vein graft, should be used as the secondary conduit to revascularize the left side of the heart, but they cannot say the same about the right coronary system. Having looked at several of the prior randomized controlled trials which compared the radial artery and the saphenous vein in CABG, we return to our initial problem. While a new clinical trial is possible to permit us to see a difference if it does exist, this trial would take years to conduct and results would not be available for quite some time. Thus, we settled on finding another way to achieve the same result. We needed to find a way to gain sufficient statistical power to assess the data which already exists. In 2015, the primary investigators of the project, Mario Gaudino and David Taggart, sought to provide evidence-based outcomes on the clinical results of the use of the radial artery compared to the saphenous vein in CABG. We have just seen that some of the existing trials on the topic have shown trends towards clinical superiority of the radial artery, but none reach clinical significance. Thus, the primary investigators returned to the problem. A study is needed with sufficient statistical power to detect a clinical difference, either major cardiac events and possibly mortality. Before proceeding with their plan, the PIs needed to calculate a sufficient sample size. The starting point for this calculation was the Syntax trial. In Syntax, the incidence of mortality at 5 years was 12%, and the incidence of major adverse cerebral and cardiac events was 27%. Thus, to detect a 25 to 30% reduction in mortality at 90% power, between 3,000 and 4,000 subjects would be needed, and to detect a 25 to 30% reduction in major adverse events, between 1,200 and 1,700 patients would be needed. Remember that the largest clinical trial on the subject from the 11 VA medical centers included only 757 patients. The primary objective of Radial was to evaluate the clinical effects of using the radial artery instead of the saphenous vein as the second graft in an individual participant data meta-analysis of all randomized controlled trials on the topic. Additionally, we stipulated predefined sub-analysis in specific subsets, including female patients, diabetic patients, and patients with non-dialysis dependent renal failure. The secondary objective of Radial was to evaluate the clinical effects of using the radial artery instead of the saphenous vein as the second graft in a large propensity-matched database, and to then compare the results of individual randomized controlled trials to those propensity-matched studies. With the idea and necessary sample size in hand, the scene was set for the annual meeting of the AATS in April 2016 in Baltimore. All of the primary investigators of the previously mentioned randomized controlled trials agreed to participate in merging all data into a combined individual patient database. Permission and ethics review was obtained from each trial committee. All data was de-identified prior to input into the new combined database. Additionally, updated follow-up information compared to the original publication was requested for all trials. With regards to merging the studies, common definitions were needed. In case of any major discordance, a further request of the raw data from the site was performed so that it could be recategorized. Once the definitions were sorted out, the homogeneous data was joined into a common database by a team of clinical information analysts based at Weill Cornell Medicine in New York City. When available, any preoperative and follow-up angiography was collected and subjected to blind reevaluation in an independent core lab. Once the database was complete, statistical analysis was performed by an independent group of statisticians based out of the Bristol Heart Institute. In addition to the primary investigators of the individual randomized controlled trials on the topic, other experts at the forefront of the field were recruited to contribute to the writing and further analysis of the results. To conclude what we have learned from the process of the Radial project, we can summarize with these 5 points. To achieve results which can alter the standard of care, extensive and arduous work must be done. The vision of the Radial project is to overcome the limitations of sample size and statistical power to answer a decades-old inquiry. Surgeons from across the world have collaborated in hopes of benefiting our future patients. Patient-level meta-analysis is not only possible, but vital when we reach an impasse in inquiry. And finally, the final results of Radial will be a landmark study in the evolving universe of arterial revascularization in CABG. We would like to acknowledge here all of the Radial project investigators and thank them all for their contributions to the study. We look forward to the publication of the final results in the near future. Thank you.